So picture this, right? You've been struggling with this severe, just mysterious joint pain for months.
Oh, which is a nightmare.
Yeah, absolute nightmare. And you finally get to a specialist and you're bracing yourself for like a mountain of lab requisitions, MRI scheduling, blood draws, all of it.
Right, the whole diagnostic gauntlet.
Exactly. But instead, the doctor just sits down, looks you in the eye, and asks you to tell the story of your pain.
Which is pretty rare these days.
It is. No machines, right?
Yeah.
Just a conversation. And that is exactly what we are getting into today. Welcome to the deep dive.
Yeah, it sounds incredibly old-fashioned, especially in a medical system that's so heavily reliant on imaging and, well, blood panels and tech.
Oh, completely.
But there is this profound analytical framework hiding inside that simple conversation.
And that framework is our mission for today. We've got this fascinating source document in front of us. It's a clinical transcript of a conversation between two medical professionals.
A mentor and a trainee, yeah.
Right. And they're essentially decoding the secret language of rheumatology. Like they're mapping out how doctors take something totally subjective, like you saying, hey, my knee hurts, and they translate that into this highly precise diagnostic grid.
Which, that is such a valuable skill. Knowledge is always most valuable when we understand why it matters, not just what it is.
Yeah, for sure.
And in an era where we sort of, default to letting a machine categorize our ailments, this transcript reminds us of the profound power of just careful listening and pattern recognition.
It's about understanding the underlying logic of the body, really.
Exactly. It's reading the body's logic.
So let's start building that logic, because if you're listening to this and trying to figure out how a doctor solves this kind of mystery, you'd probably assume they immediately ask exactly where the pain is.
Which makes sense. Location seems like step one.
Right. But the source transcript makes it super clear that before a doctor even cares about the location, they have to figure out how the pain behaves over time.
The tempo.
Exactly. Time is the first critical axis. We have to track the tempo.
The temporal evolution. It's all about how the disease unfolds. And the physicians in our source material outline 3 distinct tempos.
Which are additive, intermittent, and migratory.
Right. And identifying which rhythm you are actually experiencing is the very first filter. It narrows down this massive list of potential diseases.
So let's break those down. The first one, the additive pattern, I think that one feels the most intuitive.
Yeah, it's pretty straightforward.
Right, like a joint starts hurting and then another joint joins in. But the crucial mechanism here is that the first joint doesn't stop hurting.
It doesn't stop, exactly. The joints are progressively recruited.
Progressively recruited. It's like a choir, where the director keeps pointing at new sections to start singing, but nobody is allowed to stop.
Oh, that's a great way to put it.
The noise just builds and builds,
That's a highly accurate way to visualize the underlying pathology, honestly, because the inflammation isn't shifting around, it's accumulating.
So it's compounding.
Right. And the textbook example of this additive behavior is rheumatoid arthritis. The damage in the immune response, they simply compound over time.
Okay, so contrast that with the intermittent pattern, because this one completely clears the stage.
Right, it's a totally different beast.
A joint flares up, and then the pain just vanishes entirely.
Yeah.
It leaves this fully asymptomatic period. And the source really emphasizes that this isn't just some quiet lull.
No, it's not a dull ache. It is a true return to baseline. The inflammation switches completely off.
Which is wild to think about.
It is. And when doctors see this true intermittent pattern, particularly in an inflammatory context, it narrows the suspect list down significantly.
Okay, so what's on that list?
Well, acute gout is the most famous example, but you also see it in things like palindromic rheumatism, relapsing polychondritis, and a condition known as RS3PE.
Okay, wait. I need us to pause on RS3PE
Okay.
because the transcript drops that acronym,
Right.
and it is a massive mouthful.
It really is.
Relapsing seronegative symmetrical synovitis with pitting edema. I need a translation for what that actually means for the person experiencing it.
It is quite the title, I'll give you that. But every single word tells you exactly how the disease behaves.
Okay, break it down.
So relapsing confirms the intermittent tempo we just talked about. It comes and goes.
Got it.
Then seronegative is fascinating. It means that if you draw the patient's blood, it will test negative for the typical rheumatoid antibodies.
So the blood work basically looks normal.
Exactly. The blood work looks totally normal, even though the patient is clearly suffering.
Which perfectly illustrates why the patient's story is way more important than just blindly trusting a lab test.
Precisely. You have to listen. Then we have symmetrical synovitis, which means the spongy lining of the joints is inflamed equally on both sides of the body.
Right, so both hands or both knees.
Yeah. And finally, pitting edema. This is a very specific type of swelling, usually on the back of the hands or the feet.
Oh, I've heard of this. It's when you press on it, right?
Yes, exactly. If you press your thumb into the swollen area and take it away, it literally leaves a dent or a pit in the skin for a few moments before it fills back in.
Wow. Okay, that makes so much more sense. Every word is a specific clue.
Exactly.
So, okay, we have the building noise of the additive pattern and the vanishing act of the intermittent pattern, but I really struggled with the third tempo.
The migratory pattern.
Yeah, the migratory pattern. Because think about it from a patient's perspective. If my right wrist hurts on Monday, but by Friday my right wrist feels great and my left ankle is just killing me, isn't that just an intermittent pain that happened to move?
It sounds like it, sure.
So why does it get its own separate category?
Because biologically, there is a completely different mechanism at work. Intermittent pain fully resolves before the next distinct episode begins, which could be weeks or months later.
Right.
But migratory arthritis functions like a relay race.
A relay race. Wait, do you mean they overlap?
Yes. The baton of inflammation is actively being passed from joint to joint. So as the wrist begins to subside and cool down, the ankle is already heating up and flaring. The disease is traveling through the body in a continuous chain of events.
Okay, so the overlap is the key distinction there. That makes sense. But the transcript also points out something incredible about this relay race.
The speed of it.
Yes, the speed of the baton pass is apparently a massive diagnostic clue.
It is a huge clue.
Yeah.
If the migration from one joint to the next happens in a matter of mere hours, a doctor is going to highly suspect rheumatic fever.
Hours, that's so fast.
Very fast. But if that exact same relay race unfolds slowly, like over a period of several days, the doctor will suspect gonococcal arthritis. So the tempo of the migration is a completely separate clue from the migration itself.
See, that level of deduction is just brilliant.
It really is.
But then I looked at the actual list of things that cause a migratory pattern, and it feels, honestly, chaotic.
It's a long list.
It is. The source lists Lyme disease, chikungunya, inflammatory bowel disease, drug reactions, even SLE.
Systemic lupus erythematosus.
Right, exactly. And for anyone listening, that's lupus. But how on earth can a tick bite, a chronic autoimmune disease, and a reaction to a medication all produce the exact same migratory joint pain?
Well, that is the danger of pattern recognition if you don't understand the why behind it.
Okay, explain the why.
Migratory describes a behavior. It does not describe a single underlying biological mechanism.
I see.
So a bacterial infection from a tick bite, an immune system dysfunction in lupus, or a viral load from chikungunya, those are entirely different biological crises.
Completely different.
But they can all provoke a systemic inflammatory response that just so happens to travel through the synovial tissue in that relay race fashion.
So the tempo doesn't give you the final answer. It just gets you into the right neighborhood.
Correct. It narrows things down.
Which means, if two distinct diseases can both cause a migratory tempo, how does a doctor actually break the tie?
They have to pull out a map.
Right, this topography.
Exactly. Understanding the time lapse is practically useless unless you know exactly which anatomical territory is under attack.
Right, so we move from the dimension of time to the map of the body. And the source breaks this map down into very specific regions.
It does.
We have the peripheral joints, which are out in your extremities, so your hands, wrists, feet. Then we have the axial joints, which make up your core, like the spine and the sacroiliac joints in your pelvis.
And then there are the root joints.
The hips and shoulders.
Right, because they physically bridge the peripheral limbs to the axial core. They are the roots.
Makes perfect sense. But when doctors are looking at this map, especially out in the peripheral extremities, there is this one detail they seem to obsess over more than anything else.
Oh, symmetry. Symmetry is everything in rheumatology.
Okay, I have to challenge this, though.
Go for it.
Because if you're a patient and you come in and say, my right knee is swollen and it is killing me, why is the doctor immediately examining your completely fine left knee? It feels counterintuitive.
I get that. But it's because the doctor is trying to figure out where the attack is actually coming from.
What do you mean?
Think about the mechanical wear and tear of everyday life. If you spend 20 years swinging a hammer, you are going to damage the cartilage in your right elbow.
Sure.
That damage is localized, and it is asymmetrical because it is caused by a localized mechanical force.
The injury came from the outside.
Exactly. But if your immune system goes rogue and decides to attack the lining of your joints, It is launching that attack through your bloodstream.
Oh, wow.
And your bloodstream goes everywhere equally. So a systemic immune-driven attack will naturally be symmetrical. If the right knee is under fire from the immune system, the left knee almost certainly is too.
That is a phenomenal way to frame it. Symmetry basically means the call is coming from inside the house, systemically speaking.
Exactly.
And that brings us right back to rheumatoid arthritis. The transcript notes that RA is the classic symmetrical attacker.
The ultimate example.
It hits the small joints, it hits the large joints, the upper and lower body, but it has this brilliant little quirk. It specifically spares the DIP joints.
The distal interphalangeal joints, yeah.
Right. And for you listening, if you look at your hand right now, the DIP joints are the knuckles furthest down the finger, the ones right next to your fingernails.
Yeah, the very tips.
RA will ravage the rest of the hand, but leave those specific furthest fingertips completely alone. Why is that?
It comes down to the microanatomy of those specific joints. RA targets a very specific type of synovial tissue, and the density plus the mechanical stress environments of those furthest joints, it just differs from the larger knuckles.
So it's like a blind spot for the disease.
Basically, yes.
But what if a patient comes in and those furthest DIP joints actually are the ones involved? What does that mean?
Then the map points the doctor in a completely different direction.
Okay.
If those furthest knuckles are bumpy and painful, but there is no true synovitis.
And synovitis is the spongy, warm inflammation of the joint lining, right?
Correct. So if there's no spongy inflammation, it points heavily toward primary nodular osteoarthritis.
Ah, so mechanical wear and tear.
Exactly. It's often genetic, too. The cartilage has just worn down, and the bone is reacting by forming little nodules.
But if those same fingertips are involved, and they do have that warm, inflamed synovitis,
then you are looking at something systemic again, like psoriatic arthritis or enteropathic arthritis. The map literally changes the diagnosis entirely based on that one joint line.
it is essentially a physical decision tree playing out right on the surface of the patient's hand.
That's a great way to look at it.
And it's not just the hands. The source mentions the spondyloarthritis family of diseases, too. And their map is completely different.
Completely
They
different.
cause asymmetric inflammation. They prefer the lower extremities. They heavily involve those root joints we mentioned, like the hips, and they are famous for causing enthesitis.
Right. Enthesitis is a crucial term here.
The source defines it as where the tendons insert into the bone, but what is actually happening there biologically?
Well, the suffix itis always means inflammation. So enthesitis isn't an attack on the joint space itself.
Right.
It is a severe inflammation exactly at the anchor point, where a tendon or a ligament actually attaches to the bone.
Oh, I see.
Like Achilles tendonitis is a common mechanical version of this, but in spondyloarthritis, the immune system is systemically attacking those anchor points all over.
Wow. Okay, so we have our core rules now. We have the 3 tempos, we have the anatomical map, and we have the concept of symmetry.
The foundational grid.
Right. But human biology rarely respects a perfect textbook script, does it?
Oh, rarely. And that is where the real art of diagnosis comes in.
Yet the source material highlights these bizarre, highly specific outliers. And reading through them, it feels like these are the strange quirks that immediately trigger a doctor's spider sense. You know?
Oh, for sure. They are the patterns so specific they practically announce the diagnosis from across the room.
Yes. So let's dig into the why behind a few of these high-yield oddities, because they are just fascinating.
Let's do it.
Let's start with primary osteoarthritis again. We mentioned it hitting the fingertips, but there's another classic spot, the base of the thumb, the first carpometacarpal joint.
Right.
Why does wear and tear arthritis love the base of the thumb so much?
It is basically the evolutionary cost of the opposable thumb.
Oh, that makes sense.
Yeah, that specific joint gives our hands their incredible range of motion, right?
Yeah.
It allows us to pinch and grasp and do fine motor tasks.
Right.
But all that mobility requires the joint to endure an immense amount of mechanical stress and friction over a lifetime. It simply wears out faster than the simple hinge joints of the other finger.
That makes perfect sense. Okay, next oddity, psoriatic arthritis.
Okay.
We talked about it hitting the furthest fingertips, but the source describes this phenomenon called acute dactylitis.
Yes, dactylitis.
This is where an entire finger or toe swells up uniformly, and the medical translation is literally a sausage digit.
It is.
Why does the whole finger swell instead of just the knuckle?
Because the inflammation isn't confined to the hinge of the joint.
Really? Where is it then?
In dactylitis, the entire tendon sheath, so that's the casing that runs the full length of the finger to help the tendon glide that whole sheath, becomes massively inflamed, along with all the surrounding tissue.
Oh, wow.
Yeah, so the anatomy of the inflammation physically forces the finger into that uniform, sausage-like shape.
Incredible. Okay, then there's hemochromatosis.
Mm-hmm.
The source says it shows prominent involvement in the main knuckles, but without true synovitis,
Correct.
which happens because hemochromatosis is an iron overload disease, right?
Exactly.
So iron is physically depositing into the joint, causing pain without that spongy immune inflammation.
You nailed it. It mimics an inflammatory arthritis, but the actual mechanism is physical deposition, not an immune attack.
It's just wild how many things can go wrong.
Uh,
But the absolute king of the dramatic entrance in this transcript has to be acute gout.
Podagra.
Podagra. The source calls this the pattern of the day, and the presentation is just unforgettable.
It's very vivid.
Right. The big toe, specifically, the first metatarsophalangeal joint, it goes from completely normal to shiny, red, swollen, and just agonizingly painful within a matter of hours.
Very fast.
So why the big toe?
It actually comes down to temperature and gravity.
Really?
Yeah. So gout is caused by high levels of uric acid in the blood. And when that acid precipitates into sharp, needle-like crystals in a joint, the immune system attacks those crystals, causing explosive inflammation.
Right, but why does it crystallize in the toe specifically?
Because uric acid crystallizes at lower temperatures.
Oh,
And the big toe is the furthest joint from the core of the body, meaning it is physically the coldest joint.
that is fascinating.
Right. Add in the fact that gravity pulls fluid down while you are on your feet all day, and the big toe basically becomes the perfect chilly environment for those crystals to rapidly form overnight while you sleep.
That is mind-blowing, and it completely explains the detail that always stuck out to me, the sensitivity.
Oh, the pain is legendary.
Yeah, the source echoes this. A gout flare in the toe becomes unbearably tender to even the weight of a bedsheet
Yes,
because the joint is literally packed with microscopic needles.
exactly. It is an unmistakable presentation. And we also see highly specific combinations of symptoms, too. For instance, acute sarcoid arthritis, which is also known as Lofgren's syndrome.
Right, the transcript notes this presents as inflammatory arthritis around the ankles, but it comes as a package deal with something called erythema nodosum.
Which is another intimidating term for a very visible symptom.
Break it down for us.
Erythema nodosum refers to these painful red lumps that appear under the skin, usually on the patient's shins.
Oh, yikes.
Yeah, it is an inflammation of the fat cells beneath the skin. And when a doctor sees those red lumps on the shins combined with swollen ankles, Lofgren syndrome immediately jumps to the very top of the list.
It's like a secret handshake for the disease.
Pretty much.
But just when you think you've got all the rules and oddities figured out, the source opens up something it calls the vault.
Oh, the vault.
Yeah, where the body throws an absolute curveball.
Hmm.
Enter intermittent hydroarthrosis.
Genuinely one of the strangest entities in rheumatology.
It perfectly mimics the clean, vanishing cycles of inflammatory intermittent arthritis. Like a joint swells up massively, and then it vanishes completely, right on schedule.
Right.
But it's non-inflammatory. And it's idiopathic, meaning medical science has literally no idea why it happens.
None at all.
The body just decides to flood a joint with fluid and then drain it, like for fun.
Which brings us to a really vital caveat for this entire diagnostic framework we've been talking about.
What's that?
As satisfying as these specific patterns are, pattern recognition is only ever a rough guide. It is the starting line, it's not the finish line.
I was actually wondering about that. If the big toe is red and shiny, and we know it's because of cold temperatures and crystals, why isn't the case instantly closed right then and there?
Because human biology is messy and real-world overlap is everywhere.
Makes sense.
Like, an atypical, strange presentation of a severe joint infection could perfectly mimic the textbook presentation of gout.
Oh, and you wouldn't want to miss an infection.
Exactly. Pattern recognition helps a doctor narrow the suspect list down from 100 possibilities to maybe 3 or 4. But a good physician will never declare the case completely closed until they've ruled out the dangerous mimics.
Which naturally brings up the question of what happens next. You've narrowed it down, you've cracked the case, you've named the disease. What does this actually mean for the patient moving forward?
That's the pivot.
Right. The source material points out this crucial pivot in how doctors use all of this information. They transition from identifying the disease to surveilling it.
Yes, the transition from diagnosis to disease tracking. It is a vital shift in patient care.
The source notes that doing an objective joint count, where a doctor actually physically presses on the joints to count exactly how many are swollen or tender,
Yeah.
that isn't just for that initial aha moment of diagnosis.
Not at all.
It becomes the simplest, most effective way to measure the disease's activity over time.
And rheumatologists use formal mathematical tools designed specifically for this kind of surveillance. The math actually changes depending on the diagnosis.
Oh, interesting. Give me an example.
Well, for rheumatoid arthritis, doctors often use a tool called the DAS-28.
DAS-28.
Yeah, which stands for the Disease Activity Score, evaluating 28 specific joints.
Okay, got it. And if the diagnosis is ankylosing spondylitis, they use the Bath indices. And for osteoarthritis, they use the WOMAC index.
Exactly. They tailor the tool to the disease map.
What amazes me is that doctors are taking the exact same raw data, literally just counting swollen joints, and using it for two entirely different clinical purposes.
Think about it visually. Diagnosing the condition is like taking a photograph.
Okay.
It is a static snapshot that captures the pattern in that specific moment just to give it a name. But tracking it with tools like the DAS-28, that is a motion picture.
Oh, I like that.
It allows the doctor to see the actual trajectory of the disease over months and years. Like, are the medications working? Is the inflammation fading? The objective joint count lets them continually adapt their strategy to keep the disease suppressed.
It's a beautifully elegant system. And you can see it all come together in the case file that the source text opens with.
Ananya and Rohan's case.
Right. They have this patient, and they just apply the filters we've been talking about. First, the pain started in the wrists. Then, new joints progressively joined in without the old ones settling down.
Which is our additive pattern.
Exactly. And then you add in the chronic morning stiffness and the fact that it improves with gentle activity. And the doctors realize they aren't just looking at random, unrelated aches and pains anymore.
They are looking at a very specific shape, the shape of rheumatoid arthritis.
Less like a mystery and more like a shape. That is exactly what the trainee says in the transcript.
It's a great line.
It's such a satisfying conclusion to the detective work.
Yeah.
We have covered a massive amount of ground today. If you're listening, remember how your body speaks. Remember the three tempos: the accumulating choir of the additive pattern, the vanishing act of the intermittent pattern, and the baton pass of the migratory pattern.
And remember the map, too. The peripheral limbs versus the axial core.
Right.
The vital importance of symmetry for spotting systemic immune attacks. And of course, the underlying mechanisms behind the oddball clues, like why a cold big toe invites gout crystals.
Exactly. Why does all this matter to you? Because the next time you or someone you care about experiences mysterious aches and pains, you'll realize your body isn't just randomly malfunctioning.
No, it's communicating.
It is speaking a highly structured language. It's giving you a tempo, it's giving you a map, and it is practically begging to be understood.
And that leads to a rather profound question to leave you with, actually. Well, we've learned today that this incredible diagnostic elegance requires no high-tech machinery, right? Just careful, structured listening to the temporal and anatomical patterns of physical pain.
All right, just a conversation.
But what if other, more invisible systemic issues in our bodies exhibit these exact same patterns?
The visible issues, like what?
Like, what if things like deep neurological stress or chronic autoimmune fatigue also behave in additive, migratory, or intermittent ways? Perhaps the clues for those mysteries are already there, pulsing in a recognizable rhythm inside of you. It's entirely possible we just haven't developed the clinical vocabulary to listen to them yet.